I will share with you a presentation about ultrasound-guided injections for management of temporo-mandibular joint internal derangement. The temporo-mandibular joint is a synovial hinge joint at which the mandibular condyle articulates with the temporo-mandibular fossa and articular eminence. Despite its small size, the temporo-mandibular joint has a relatively big range of movements, including protrusion and retraction, a side-to-side translation, and a rotation and opening and closing the jaw. These movements allow various essential actions like biting, chewing, speaking, and yawning. A normal disc together with the stabilizing ligaments and the masticator muscles serve to provide synchronized and coordinated temporo-mandibular joint movements. Internal derangement is an alteration in the disc positioning and hence joint mechanics. The patients may be presented by different symptoms like pain, clicking, jaw locking, and limited opening. It may progress up to joint degeneration. The etiology is unclear. However, various psychological, hormonal, and hereditary risk factors were described along with joint overuse. The diagnostic criteria of temporo-mandibular derangement were recently updated, and according to which internal derangement may present as disc displacement with reduction and intermittent locking. Compared to normal side, T1 closed MRI showing anterior disc displacement with reduction in open mouth view. The third and fourth criteria were disc displacement without reduction, with or without limited opening. Compared to normal side, T1 closed MRI showing anterior disc displacement without reduction in open mouth view. The management goals are to identify and control the cause, decrease functional load and reduce inflammation, resulting in less pain, increasing range of motion, and restoring function. The first line of treatment is usually conservative, including physiotherapy, medications, and splints. Intra-articular injections could be ultrasound-guided or non-guided. They are usually considered as an alternative when conservative treatment fails and before directing the patient to endoscopy or open surgery. The last option could be surgical. The effectiveness of minimally invasive procedures has significantly reduced the frequency of disc repositioning or discectomy surgeries. Regarding intra-articular injections, sodium hyaluronate and corticosteroid injected in the superior joint space are designed to treat internal derangement with both regenerative and degenerative responses to such injections. The pathophysiology of the disease indicates there may be more significant potential for these injections in the early stage of degeneration. Arthrocentesis and arthroscopic surgery are minimally invasive techniques requiring entrance into the joint capsule to lubricate the surfaces. The joint is flush of debris and inflammatory cytokines using a sterile draining solution. Through arthroscopic surgery, the surgeon may also break intra-articular adhesions. Proliferation treatment or prototherapy is another example. It's also described as a regenerative and growth factor stimulation injection therapies. There are different classes of proliferative agents, including irritants, particulates, osmotics, chemoattractants, and growth factors. It gives a long-term solution through strengthening the ligaments, tendons, and capsule. Dextrose is an example of one of the most investigated prototherapy agents. Why dextrose prototherapy? Dextrose is implicated as an independent agent in pain reduction. Besides its availability and low cost, it has no major reported complications or side effects to date. Post-procedure arthroscopic evaluation further suggests a chondrogenic effect of dextrose. As this modality can be repeated monthly, dextrose prototherapy is not associated with cartilage degradation or atrophy of connective tissue as seen with corticosteroids. On the other hand, corticosteroids may be associated with accelerated osteoarthritis, complications of osteonecrosis, soft tissue atrophy, increased risk of infection. Compared to the complexity and cost associated with both botulinum toxin and platelet-rich plasma injections, this injection technique stands out as being safe, elegant, well-tolerated, and reproducible. Why ultrasound-guided injections? The utilization of ultrasound guidance for joint intervention is widely accepted among different practitioners. Besides its availability and lack of ionizing radiation, it provides anatomical details which facilitate and allow a more accurate and targeted approach. Ultrasound-guided temporo-mandibular injections are accomplished with a higher accuracy and lesser pain as compared to conventional blind techniques. Regarding technical considerations, the patient is placed in a side-lying position with the head turned to the opposite side. The high-frequency linear transducer is placed in a coronal orientation. In order to obtain diameters, the angle of insonation must be positioned orthogonal to the long axis of the condyle. Ultrasound anatomy reveals the mandibular condyle and the articular eminence of the temporal bone. The injection could be prepared by mixing 1 ml of isotonic saline, lidocaine, together with the injectable material. Under aseptic conditions, an in-plane technique is used to inject 2 ml intraarticular into the synovial pouch, with the injectate filling the space, exerting effects on the synovial tissues, mandibular cartilage, and retrodiscal tissue. The pitfalls and complications of intraarticular injections could be inadequate angulation of the probe, which may result in out-of-plane injection, temporary pain or swelling of the affected joint. In some patients, facial muscle weakness, numbness, dizziness, or allergic reactions can be seen. A study conducted in our department, including 22 patients with a total of 43 affected joints with a reducible disc displacement proven by MRI. The patients were divided into unguided and ultrasound-guided groups. The procedure involved injection of 2 ml solution of a mixture of saline, lidocaine, and dextrose using a 25G needle in the joint and 1 ml intramuscular injection to the masseter muscle at the most tender point. The visual analog score was used to compare joint pain intensity over different time periods, beginning with the pre-injection, 1, 2, and 6 months post-injection. The dextrose injection reduced the symptomatic pain clicking over time in both groups, but ultrasound-guided group showed a statistically significant improvement compared to the non-guided group. A 25-year-old female patient complaining of a painful clicking left temporomandibular joint. The patient had a previous MRI and was diagnosed with reducible anterior disc displacement. The patient then sought medical advice in the oral maxillofacial department and was referred to the radiology department for ultrasound-guided prototherapy injection. T1 sagittal MRI closed view showing anterior displacement with reduction in the open mouth view. Ultrasound before dextrose injection showing the normal temporomandibular joint. Ultrasound after pericapsular dextrose injection with the arrow pointed at the tip of the needle. This video showing the entrance of the needle. With the pericapsular dextrose injection into the joint space. In conclusion, internal derangement is the most common temporomandibular disease. Altered disc positioning directly impacts the joint mechanics and function, while corticosteroid preparations, solely or with hyaluronates, are the most universally injected material to help reduce pain. There is a growing interest in using proliferative agents that make a long-term solution through strengthening the ligaments, tendons, and capsule. Intraarticular injections reduce painful clicking in patients with temporomandibular internal derangement, with the results encouraging the use of ultrasound guidance for more accurate anatomical localization. Thank you.